So we've already dropped Dr. Timea Hodics' name a couple of times. She's our last speaker for this session. Dr. Hodics is a vascular neurologist, a colleague of mine at Houston Methodist Hospital. Dr. Hodics was medical director of stroke programs at Georgetown and UT Southwestern before joining Methodist Hospital. She's an expert on the emerging modalities of stroke recovery, including transcranial direct current stimulation and vagal nerve stimulation. And I'm excited to hear her talk on stimulating new approaches to stroke recovery. Take it away, Dr. Hodics.
First, they ignore it, then they laugh at it, then they say they knew it all along. Alexander Humboldt, one of the greatest explorers, scientists of the turn of the 18th and 19th century, could have said this about stimulating the brain as well. Today, I will talk about the FDA-approved VNS application to enhance stroke recovery. We will cover the basic science and the clinical studies and practical applications. And I will also mention other methods under investigation that are not FDA approved yet. The FDA recently have approved the vagal nerve stimulation to enhance stroke recovery as a breakthrough device. And this investigation is here reviewed in both in the basic science and the clinical aspects. This device acts as an implanted pacemaker for the vagal nerve, where the stimulator is implanted under the skin near the clavicle, and the wires are tunneled to the left cervical segment of the vagus nerve to encircle it with electrodes. And you can see a small image here on the picture. And the vagus nerve stimulation had already been approved for treatment of drug-resistant epilepsy and depression. In addition, there is a handheld non-invasive version is approved to treat different types of headache and PTSD of this vagal nerve stimulation. And also an auricular non-invasive VNS stimulator is under investigation. So first, we will review the animal models and the evidence derived from these models. The vagus nerve stimulation paired with motor training enhances synaptic reorganization after stroke through the release of plasticity-promoting neuromodulators, such as acetylcholine and norepinephrine, as you can see in the picture. The rats that receive a VNS paired with motor training, that is indicated with the red bar, after stroke demonstrated a significantly greater increase in corticospinal tract connectivity to rehabilitated muscles compared to equivalent training without VNS. That's the blue bar. Corticospinal tract connectivity originating in both ipsilesional and contralesional hemisphere was increased. These findings indicate that VNS drives large-scale reorganization in motor networks after stroke, which may underline the recovery of function observed. The vagus nerve stimulation-dependent motor recovery is demonstrated on this image. In A, the VNS paired with rehabilitative training, marked in red, significantly improves recovery of the forelimb motor function compared to equivalent training without VNS in a model of cortical ischemic stroke. And similarly in B, the similar results were observed in cortical subcortical chronic ischemic strokes. And on the third panel on C, the same is observed after hemorrhages. The top panel on each shows a representative brain cross-section of the rat's brain. The symbol star on each one represents p less than 0.05 across groups and each time point. Interestingly, the investigators titrated the electric current between 0, 0.4, 0.8, and 1.6 milliamp, and surprisingly found that the higher intensity stimulation was not found to be more effective than 0.8 milliamp. This is in particular surprising because, as we know, the other applications, depression and seizures, require higher amperage. In fact, what they found was that at 1.6 milliamp, the effect was not present. This slide represents the summary of the preclinical studies for vagus nerve stimulation and represents a significant improvement in motor recovery across these studies. This meta-analysis shows that you can see in blue in the bottom, on average, the response favors VNS plus rehab significantly between all these applications. The markers denote standardized mean difference for VNS plus rehab compared to rehab alone for each study, and the horizontal lines indicate the 95% confidence interval. The size of the indicator represents the number of subjects, and the blue bar, as I mentioned, the blue diamond represents the summary effect. These are the human clinical trials, the 3 clinical trials that the approval was based upon. All of the 3 studies used 6-week outpatient therapy. In Dawson's original 2016 study, there was the enrollment occurred after 6 months. More than 6 months after the ischemic stroke in the UK. This study was only single-blinded. Only the assessor was blinded because the VNS was only implanted in the active group. And the control group that received rehab only did not have VNS implantation. The other 2 studies, Kimberly and the VNS rehab, the multicenter trial, they both implanted VNS in both groups. And to improve blinding, they started each session with a quote-unquote tickle of activation of the VNS, whereby the VNS was stimulated at 0.8, then 0.4, and titrated down to imitate the sensation that the active stimulation would evoke. Kimberly and colleagues in 2018 enrolled patients from 4 months to 5 years from stroke. So that's somewhat subacute and chronic, early chronic and late chronic applications. One could argue that perhaps the 4 months out time frame is a qualitatively different patient than at 5 years, and therefore they changed the enrollment criteria for the definitive study to start only at the clearly chronic time frame, 9 months out. They enrolled patients up to 10 years. The application was first 6 weeks long in-clinic application that was followed by a home exercise program. During the first 30 days of this exercise program, neither groups had real stimulation. And the stimulation for the Verum group started after that first month, to make sure that the patients were sufficiently trained to be able to trigger their stimulator at home. Both of these studies were triple-blinded, randomized, assessor and therapist, and patient-blinded. The Kimberly and colleagues study was also a crossover study when they added a second long-term home therapy for those patients that were originally in the sham group and evaluated them with Verum real VNS treatment. The first two studies were small studies. The Dawson study was 20 patients, 9 VNS and 11 rehab patients. Kimberly and colleagues studied 17 total patients with 8 VNS and 9 control patients. And all of them had 6-week therapy, 1 month and 3-month assessment. The VNS rehab, the definitive multi-center study, then enrolled patients that had active wrist flexion and extension and active abduction and extension of the thumb, so some residual distal motor function. But all of these studies enrolled moderate to severe patients. That is Fugl-Meyer scale 20 to 50. That goes from 0 to 66, with 66 being a normal score, 0 being no motor function of the upper extremity. The Fugl-Meyer scale is a commonly used impairment scale in upper extremity motor recovery studies. Here we can see a visual representation of the therapy. And as you can see, it was very well designed. The therapist presses a push button trigger that corresponds to the time when the patient performs a successful motor task. The stimulation is a 0.8 milliamp, 100 microsecond, 30 hertz stimulation pulse, and that lasts 0.5 seconds. Participants received during the 6 weeks of in-clinic therapy 3 times per week treatment, a total of 18 sessions, followed by a home exercise routine. The therapy tasks were very carefully designed. They were divided into 7 categories for uniformity, and the tasks were adapted to each person's ability and goals. The therapy was progressive, functionally relevant, and individualized and intensive. 18 sessions over 6 weeks. Each started at 5-10 minutes of stretching. Participants performed 300 to 500 total tasks per session, so it's high intensity, with approximately 30 to 60 repetitions. The 6 tasks would be done in the same order at each session, more than 300 repetitions per session. Tasks were continually adapted to remain achievable by challenging to achieve optimal improvement. And then the therapy was followed by a home-based therapy that was designed also by the patient's therapist using the same categories of tasks. Written and verbal instructions were given, and the patients were asked to practice for 30 minutes per day. At the start of the session at home, participants activated the VNS device via magnet swipe over the site of the IPG. The stimulation occurred every 10 seconds thereafter for 30 minutes after the magnet activation. And the patients were monitored by biweekly calls. The clinical trial results. Again, the main outcome measure was the Fugl-Meyer scale, which is the most commonly used motor impairment scale for the upper extremity. And as you can see here, the average improvement was 6.6 on this scale, which is rather impressive, as more than 5 points improvement on this scale is considered clinically meaningful improvement. They also used an interesting outcome measure, the response rate. The response rate is a percentage of patients achieving clinically meaningful benefit, and that was about double on all of these studies. The other two studies had a similar design, as we mentioned, and the Vogelmeier score differences were similar, slightly more modest. You remember that the Dawson study, the original study, was only single-blinded. The other two was triple-blinded. But uniformly, we see that the improvement after the complete therapy is roughly doubled in the VNS treatment group compared to the control. Impressively, the VNS rehab multicenter trial found that the number needed to treat to have benefit from VNS treatment is only 4.3. The study device-related adverse events were generally mild and reversible, mostly related to the surgical implantation and post-surgical pain, as expected. There were one vocal cord and phrenic palsy, one nausea, one metallic taste, one dysphagia, and 5 cases of hoarse voice or tingling during the stimulation in the original 2016 study by Dawson. The severe adverse events were thought to be not related to the stimulation. One was a paroxysmal atrial, the other colon cancer in the active group, and chest pain, dyspnea, and ureteric stent in the controls. Overall, there were 22 adverse events in the VNS group and 10 in the control. In the Kimberly study in 2018, there was one wound infection, one shortness of breath, dysphagia, and hoarseness events that were related to the implantation, and 21 total adverse events out of 15 patients from the 17. Most of them were pain and bruising at the surgical site. The severe adverse events, again, were similar, like in the Dawson study, and they were not related to the implantation or the stimulation. And finally, in the VNS rehab multicenter study, again, similarly benign adverse events were observed. There were 3 severe adverse events observed in 2 patients in the VNS group, 1 each of urinary tract infection, hyponatremia, and insomnia, and 2 severe adverse events in 2 participants in the control group, 1 headache and 1 syncope. Postoperative pain was the most common adverse events. It occurred in 13 of the VNS group and 9 in the control group. I'm wondering who wouldn't experience postoperative pain after a surgery, but that's what was reported. Kimberly from the 2018 study has shown in a follow-up study that the sham group, after completing the therapy, when crossed over to receive VNS treatment, also improved to similar degree as the original VNS treatment group. Here we can see a summary of preclinical and clinical studies evaluating the relative improvement between the VNS and the motor treatment only group. And as you can see, on average, the improvement is about twice as much in the VNS treated group than the motor therapy only group. And lastly, I want to close this discussion with a brief overview, and admittedly very superficial overview of applications that might come to your clinic in the near future. The first image is a transcranial direct current stimulation in my previous lab at UT Southwestern. That uses a non-invasive battery-powered device, as you can see, to stimulate the specific parts of the brain. A constant low intensity current is passed through the two electrodes that are placed in different areas of the brain, of the head, and it modulates neuronal activity. There are two types of stimulation with TDCS, a nodal and a cathodal stimulation. A nodal stimulation acts to excite neuronal activity, while cathodal stimulation inhibits and reduces neuronal activity. Several studies suggest it may be a valuable tool for treatment of neuropsychiatric conditions such as depression, anxiety, chronic pain. Research has also demonstrated cognitive improvement in some patients undergoing TDCS. However, currently TDCS is not an FDA-approved treatment, but used as off-label clinical application to improve stroke recovery in several academic centers around the US and internationally. It is approved in the European Union, for example, for the treatment of pain and depression. Although transcranial direct current stimulation is still an experimental form of brain stimulation, it potentially has several advantages over other brain stimulation techniques. It is cheap, it is non-invasive, it's painless and safe. It is also easy to administer, and the equipment is easily portable. The most common side effect of TDCS is a slight itching or tingling on the skull. The TDCS is evaluated as neuroprotection in acute ischemic strokes and as an add-on therapy for stroke recovery currently in 264 studies that are registered on clinicaltrials.com. The second image represents transcranial magnetic stimulation, where electromagnetic pulses that are generated by the stimulator trigger small electric currents inside the brain. And despite this picture, it does not make the skull transparent. And it is used currently in an FDA-approved application to treat drug-resistant depression, obsessive-compulsive disorder, and anxiety disorders. It has been evaluated in approximately 300 stroke clinical trials. Of those, about 80 are recruiting or about to recruit. A total of 34 meta-analyses were published until 2021 in the English language literature. These focused on effects of motor function, manual dexterity, walking, balance, spasticity, dysphagia, aphasia, unilateral neglect, depression, cognitive function after stroke. Although several paradigms resulted in clinical improvements, routine use of a specific paradigm of stimulation cannot be recommended yet due to the significant level of heterogeneity in the studies in terms of protocols and outcome measures. An interesting version of TMS is demonstrated on the third image. This is an FDA designated breakthrough device that was announced in January 2021 based on 25 stroke patients that had dramatic improvements with this version of magnetic stimulation. This uses an AI-powered electromagnetic field to alter brain activity. It uses as an input EEG brainwaves and a proprietary learning mechanism algorithm that translates this into a frequency-tuned, low-intensity electromagnetic field to enhance plasticity. Pivotal RCT of 150 patients over 9 weeks of therapy 5 times a week for 1 hour treatment associated with physical therapy and occupational therapy is currently ongoing. The primary outcome measure will be MRS, which is quite interesting because MRS is considered a less sensitive outcome measure than the most commonly used Fogel-Meyer scale. A novel multifocal magnetic stimulation that is demonstrated on the fourth image here method was invented here at Methodist Hospital by Dr. Santos Halakar and Henning Voss, named transcranial rotating permanent magnet stimulator, or TRPMS. This allows simultaneous stimulation of multiple areas of the brain, and yet allows free movement of the patient, making physical therapy easy to implement. It seems to marry the best aspects of the previously mentioned TDCS and TMS. TRPMS produces a maximum stimulus strength of approximately 7% of the conventional TMS at cortical depth of 2 centimeters. The stimulus is much more focal, therefore, with a spatial spread of 1 to 2 centimeter, and stimulus frequencies are lower. The oscillatory pulse is longer, 25 to 100 millisecond duration, which might be a more physiological stimulus. TRPMS is portable, wearable, battery-operated design, allowing future in-home therapy, consistent delivery of focal stimulation unaffected by head movement, and resistance from electric shock. There is no skin irritation. Dr. David Chu led a phase 1 to 2A double-blind sham-controlled trial here, and as a result of the success of this initial trial, is currently assembling a multi-center pivotal clinical trial to test the efficacy of this, in my opinion, promising approach. There are several other kinds of less studied applications that we won't talk about given the short time given for this lecture, such as static magnetic stimulation, transcranial alternating stimulation, transcranial random noise stimulation, ultrasounds, and near-infrared laser applications, for example. There is also one study that has been evaluating the implanted deep brain stimulation to enhance stroke recovery, as you can see in the image. Again, we learned about the FDA-approved VNS to enhance stroke recovery, and we reviewed the basic science and the clinical studies, and reviewed the clinical applications as to how we will apply this to our clinic patients, and briefly reviewed other methods under investigation that might be coming to your clinic in the near future. And here are my references. Thank you very much.